much. And I'm more like I'm an engineer, so it's quite good. Like for me to working on all the ocular drug delivery is kind of a translational research. So, but right now in the Weimar Institute, we have a center called the Nanomedicine Center. So we collaborate very closely with all kind of all different kind of segments of the eye. For my research, specifically focused for the cornea, and Professor Chen just gave a very nice talk about the corneal lymphoangiogenesis, and for me, but I just can follow up the story, tell you share you some of the some research we just achieved by using the nanomedicine to treat corneal allograft rejection. And as we know, corneal transplantation, and I think it's about, but right now it's about like nearly 50,000 cases in the United States only. And for the normal risk corneal graft, which means there are no blood vessel, no inflammation, corneal bed, and the rejection rate about 2 years is about like 10%. However, for the high risk, such as very inflamed or with a lot of blood vessels, then the risk is about like survival rate is about 50%. So the immunologic graft rejection is the main cause of the graft failure. However, I think right now the treatment, majority treatment is a topical eye drop, like intensively applied after surgery, like every 1 hour or 2 hours during the first week, and top down to like every 4 times or 5 times per day. And they should last about like 6 months or even longer for during the after surgery. So it can cause a poor bioavailability from the eye drops, and also the poor patient complaints, especially for the older patient and the pediatric patient. So then we are thinking about how can we make use of nanomedicine to treat the corneal allograft rejection. So from here, we generate nanoparticles which can just loading the gold standard drug, like a corticosteroid. Here is dexamethasone. We set up the corneal rejection model. Then we try to do like a sustained release of drugs after the local administration. The principle here is that we make use of a special method, but I'm like a more pharmaceutical guy, so here's more chemistry. If you don't understand, it's fine. The main principle is just like we use a formulation method can encapsulate the water-soluble steroid, dexamethasone sodium phosphate, into polymeric nanoparticles, get a size around it's about like 200 nanometer, and its surface charge is neutral. I mean, when I talk about surface charge, it's more for the biocompatibility, because when the nanoparticle is very highly charged, no matter positive or negative, sometimes it can cause some inflammation after local administration. Here we use materials, biomaterials PLGA, which has been shown a very long-term safety, approved by FDA use for the suture, everything. So the drug content, we get about 8% by weight in the nanoparticles. The drug release in vitro can show about like nearly about 1 week or 2 weeks. So majority drug will be released during the first week. So that's why we designed the therapy just using the subconjunctival injection weekly, because the in vitro drug release profile. And then before we do the treatment, I just want to find how long time of the nanoparticle can stay after subconjunctival injection. And we use a different kind of size, 100, 200, and 500 nanometer. Here we don't use a biodegradable particle, because when the biodegradable particle used, the polymer will be degraded. So the fluorescence, if you have fluorescence in the polymer, the fluorescence dye can either be cleaved and released from the particle. So the fluorescence signal cannot represent the retention of the nanoparticle. Here we use a non-degradable particle, polystyrene beads, which coated with polyethylene glycol. It's kind of bioinert material. This is kind of mimic the biodegradable particle we used. However, the dye, it's kind of a permanent stay in the particle. They can permanent stay for forever. So here we test about 2 months. During the whole 2 months time after the first leakage, because the injection, after injection into the subconjunctival tissue, there was a hole, so the nanoparticle can leak from that part. I think it's nearly 60% of the particle will leak out during the first 6 hours. Afterwards, the particle can be permanently stay there. So, which is good for us. I mean, if you give enough dose after the leakage, the drug can permanently stay there and sustain the release locally, give us a good drug level. And then we try to test if the nanoparticle are safe. So we inject the nanoparticle. Oh, this is a biodegradable particle without the drug loaded, because steroids could potentially give us anti-inflammation effects. We just want to see the carrier, the vehicle is safe. So we can test about the particle injected into the tissue, the subconjunctival tissue showed quite similar inflammation, just like you inject the saline. So which means it's good. So then we move to our corneal transplantation model. We from here we can find we using the same species but 2 different strains. We use both inbred. One, the corneal bed is Louis rats, and the corneal the donor tissue is from Fisher. But because we try to get a nice transplantation, so that's why I pick up the rats, not mice. Mice is a little bit difficult for the technical, for the surgical techniques. So after the transplantation, we do subconjunctival injection of our nanoparticles, about 50 microliter. But we can see it get a big swell, and because with the time, actually it's kind of within 1 day, this kind of like a space can just collapse. Only particles stay there. The water can be absorbed, so it's totally fine. And we follow up 9 weeks for the control groups, saline and placebo nanoparticle-free DSP. We can see all the grafts were rejected within 2 weeks or 4 weeks. Showing tons of blood vessels, the opacity of the cornea and edema. However, if you look at our DSP nanoparticle treated group, the corneal graft remain as clear, and there are almost no blood vessel grow into the allograft. And we only start about 9 weeks. We haven't followed up for even further. But even for 9 weeks, until during the whole study period, the cornea showed non-rejected. And I think how can we explain the so superior effects from the nanomedicine? We do the ocular pharmacokinetics after the subconjunctival injection. If you see here, this is we collect the whole eyeball. We can see for the nanoparticle, we can get a very nice retention. The retention of the drugs in the conjunctival tissue. However, for the free drug, during the first 2 hours, they drop to 0.4%, which means almost all the drugs just leak out, or they just cannot stay. They just gone. And within the 1 day, there were almost no drugs there. So, but for our nanoparticle, within 7 days, even at the 7 days, about 5% of the drugs still in the conjunctival tissue, which can result as very nice drug levels both in the anterior chamber and also in the vitreous. And if you look at the anterior chamber, the drug level is super high. It's really, really high. And even we don't inject that much of the drugs. So, as we know, for the corneal rejection, it's kind of very severely happen during the first week. If you don't really good to prevent the immune response, then they can generate a very bad, a very quick rejection. But if you look at, we have a very high level of the drugs in the anterior chamber, so that could be the reason to get us very good efficacy for the. And another thing you can notice in the systemic drug levels is constantly low. So that could be nice for certain drugs if this drug can show very bad, severe systemic side effects. So when we look at the clinical evaluation, just like what I mentioned, for the edema, transparency, and the neovascularization for the DSP nanoparticle treated, they are all very, either there were no, there were no this kind of edema or opacity, or like a very minimum corneal neovascularization. But during the whole 9 weeks treatment, we can show 100% survival for the allograft if you treat it with DSP nanoparticle. So another thing we need to be, as we know, when the steroid was used, the elevated IOP is always a concern. So we follow up the IOP during the whole 9 weeks study, and a study showed in the literature in rodents, if you do like a topical eye drop of the dexamethasone for like 3 times per day, these mice will generate the increased IOP within like 2 weeks. But good thing for us, even we follow up 9 weeks, we haven't observed very severe elevated IOP. I mean, this could be either we don't use that kind of high level of the drugs, or maybe we just need to follow up long term. But so far, it's okay for us. And when we do the histopathology study of the corneal transplantation, just further to confirm the tons of inflammation and the blood vessel, and also the thickening of the cornea. They just like for the control groups, they just totally lost their intact structure of the corneal graft. But for the DSP nanoparticle treated, actually for an engineer, when I look at these eyes, I just feel like these animals haven't done any transplantation. It's just like a normal eye. So if you look at the thickness of the cornea, I cannot see there are no any blood vessel, all these kind of things. So which means this is quite promising. So in summary, I want to say, DSP nanoparticle can provide a sustained release of drugs, and which will not cause inflammation and or potential safety issue. So this could be, and also all the materials to make the nanoparticle are, we call it like allograft materials, generally regarded as safe materials approved by FDA, which can give us a chance to for a easier translational application. So another thing, just locally controlled release of corticosteroid may reduce the rate of corneal graft rejection, especially for in clinical settings. Maybe during the first few days after the transplantation, very intensive steroids are required, especially during that time. I think this kind of sustained release of the drugs could be very beneficial. And another thing, like a sustained release can enhance the compliance, and also potentially can improve the efficacy. So. This is for our center, and I work together with Walter Stuck and Justin Hans is the director for the center. So thanks for the funding, and any question, please ask. Yeah, thanks. Yeah.
Nanoparticle, the purpose is to enhance the penetration and the surface exposure.
Actually, it's not. Mm-hmm. Mm-hmm.
200 and the 500
Mm-hmm.
Mm-hmm. And do you have data suggesting that different sizes have different penetration and the reaching to intraocular concentration differently, particularly AC and the vitreous cavity?
Okay. Actually, I want to give a brief introduction about the nanomedicine used for the corneal application. Actually, to be honest, I don't think. It's very controversial. Yeah, for my study, I don't claim my particle penetrate any ocular barrier. I just using the nanomedicine as a carrier to sustain release of drugs and give you a chance for easier injection. And this is the purpose. I don't think these nanoparticles, they will penetrate any, no matter cornea or sclera. No, they are not. Yeah, and even zero, I mean, I review quite many papers. You know, they are talking about nanomedicine to improve the all.
Yeah, excuse me. You must have heard the mucus penetration.
Yeah, that's from our lab actually. Yes.
Yes.
Yeah.
What's your thoughts about?
Actually, even for the mucus penetration particle, we also don't claim this particle penetrate ocular tissue. We just claim this particle because they can penetrate the mucous barrier, give you the chance to avoid the clearance. So just they can be retained better on the ocular surface, which gives you a chance to get a better drug exposure. It's not penetration through the ocular tissue. Yes. Yeah, please.
Lymphatic drainage
Mm-hmm.
through subconscious injection.
Mm-hmm.
Because there is sizes the particle you use. What's the minimum size of the particle that can prevent extensive lymphocyte?
Yeah, actually, for the leakage, and we when for this study, I started from 100 until like a 500. Looks all the different size, you know, they show the similar like a particle or leakage. However, when I increase the particle size to like a 5 macron or 10 macron, then there are very minimum drug leakage, like a particle leakage, just because these particles they sediment very quickly and they just block the injection site, so they don't come out. But when the particle size increased, that can affect my drug release profile. So in this study, I prefer using the nano size because at this nano size, I can get better drug release. So it's kind of a combination of retention and like drug release and the safety. Yeah.
Hello.
Yep.
Ching from Detroit, Michigan.
Yep.
I was wondering, how do you control the kinetics of the drug release, these nanoparticles, if you have to keep it for a long time? So it could be like bursting over release and overdose.
Because this is we use a biodegradable polymer, and for the biograded for these polymers, there are like two different kind of mechanism to get to the drug release. Like either the direct diffusion, the drug diffuse out from the particle. Another way is just like because the degradation of the polymer. For this study, because we want to get a very good drug loading, we need to make use of the terminal carboxyl group. So that's why I use a very low molecular weight of the polymer. The polymer is the molecular weight is only 3,000 Dalton. It's very, very low molecular weight, but I can get very high drug loading and also very steady drug release. But if you want, actually, we also want to do like a once monthly injection of this nanomedicine. Actually, we have done that. We have finished this work already. Then you can use like a different polymer, such as use polylactic acid. That's purely, it's much slower degradable polymer. Then you can get like a month's release or even up to like a 3 months release. It's no problem. Yeah. It's more like a control by your materials, by your materials. Yeah. Yeah, please. Thank you.
I was just wondering, so you actually did histology.
Yeah.
When you see, when you look at under the histology, are the nanoparticles become intracellular or actually staying extracellular?
Actually, here we use some nanoparticle just like this lady's question. We don't use their like a so-called penetration or internalization. We use a nanoparticle just as a control release carrier. We never claim our particle can penetrate or internalization. Actually, it's very how to say, it's very difficult to do that kind of things because, yeah.
If you think like, there's macrophage, all those phagocytosis going on, they definitely can be internalized to the cells, right?
The potential, yes,
Yeah.
yes.
But that's really not a major thing. So have you guys tried to use this nanoparticle to deliver like nucleotides, like small RNA, siRNA?
We did, but using different polymer, different carrier. We in our lab we also do a lot of gene therapy.
Yeah.
gene and non-viral gene carrier is like half of our lab's research, and this kind of biodegradable polymer nanoparticle is another different story. Either we can loading anti-cancer drugs or steroids, like immunosuppressant, and also for anti-angiogenesis, all these kind of things. Yeah.
So if you want to make this biodegradable, how long do you want them to be there?
This
case.
It's really depend. For this case, I think my clinical mentor, they want this particle can be stay there for about 1 month. Just like especially during the first month for patients, they really need to get constantly level of the drugs during the first months. After that, then they really can do maybe a 1 time per day of the eye drop. They don't really need this kind of system, but during the first months, they need this kind of system. Yeah.
Thank you.
No problem. Yeah.
Hi, I am from Case Western. I have a question regarding your safety issue. In your slide, you have graded like neovascularization and the edema 1, 2, 3. Mm-hmm. So how did you grade like 1, 2, 3?
This is done by my a clinical fellow, and there are a table. This if you see this table is kind of established, in the literature. You can just follow the table. When you see the blood vessel reach to the graft, the ball, then you can give a score, maybe a 1. If you reach into the center, then you can give the 3. And for the edema, for the transparency, you also can see, if you can see the iris, if you cannot see iris, that all these kind of things, you can just judge based on this kind of criteria. Yeah, no problem. Maybe some people has a question for Professor Lu? No? Okay, good. Yeah, thanks.
I have a comment. This reminds me, what is it, like 10 or 15 years ago in Singapore, we were implanting this anterior chamber.
There were implants, yes.
Yeah, there's these little implants, and that some of those released steroid or antibiotic or an immunoregulatory drug, no? So it reminds me, because all the corneal rejection comes from the endothelium.
Yeah.
So by putting these implants in the anterior chamber, then it was very close by, and the levels of the drug in the other tissues are really low, really low. All this absorption of the drug to the systemic circulation was almost 0, and the graft rejection level was very, very low. So this kind of system to put any drug and deliver it to the right place, it reminds me. So when you spoke about putting a subconjunctivally, then you do have this absorption, and you do have a corneal graft rejection.
Prevented.
The advantage to do a bit clear, when you deliver to the subconj, because of the blood vessels very near to the limbus, it will help, and it could prevent, or it could really resolve the problem. If you put it in the anterior chamber, it might be a bit more effective, being just in true contact with the endothelium.
Yeah, it's a really good comment, and but if you look at our ocular pharmacokinetic study, the data, actually we got very good, very high level of the drugs in the anterior chamber.
Right, I saw.
So I think the beauty of this work, we use a water-soluble steroid. Right. So as we know, for the topical eye drops, if you have a quite lipophilic steroid, it has very good penetration through the cornea. However, for the water-soluble steroid, they don't. But in the subconjunctival or a transscleral route, the water-soluble drugs should much better than hydrophobic drugs. So that's why for some people using the cyclosporine A, there were some cyclosporine A implant. They try to
in a
implant in the
pellet.
subconjunctiva. However, they are not effective to prevent the corneal transplantation rejection. They just all reject it. I think the purpose is just because, that's my understanding, because I think that's just because this drug cannot reach into the intraocular. Yes, the drug was there, but they just cannot go to the ocular tissue. So that could be the reason. But maybe when we do this work, the clinical requirement, they just say, I want to give my patients, after surgery, give one injection of the steroid. That's it. So he want to do this and can send the patient back to home, and maybe a month later, then come back to the office and visit it. So that's why, our ultimate goal want to develop some this kind of formulation really can give you a 1 month drug release, which can more close to the translational application. So this is the goal, yeah.
Yeah, I think that's still the delivery of the drug by drops. It's probably the most, in a way,
Yes.
very safe.
Yeah.
Because although this anterior chamber devices or the subconjunctival,
Surgery, that's a surgery.
yeah, you need to. It's quite invasive, although it's very quickly
Yeah.
and very safe. It's truly very safe.
Yeah.
It is going in the eye, either subconj or in the anterior chamber.
Yes.
Anterior chamber, it's very risky.
And also you potentially can see them floating in somewhere. Yeah,
Right, you
yeah,
can.
Yeah.
So although all these things are really good ways of preventing or treating corneal graft rejection, if you have a steroid contraindication or a systemic contraindication, we need as corneal surgeons to have different alternatives to treat it.
Yeah.
This is very interesting.
Yes, thank
and,
you.
We just need to think how good is to invade the eye with a subconjunctival injection, especially for older people might not be a problem, but for children it is.
For children,
So-
definitely it is. Just like if IOP generated, then how can you stop it?
Right.
So if the drug is still there, so definitely we think about that. And another thing, why we prefer subconjunctiva over than some other intraocular device or injection, because subconjunctiva, it's when the surgeon just do the transplantation, after transplantation, normally in the Weimar, our corneal surgeon, they just do one subconjunctival injection of steroid plus antibiotics. So anyhow, they will do that. So such as inject 0.5 ml. Then my mentor, he's a surgeon, and he feels he just want to give his patient like this. This is what he want. He don't. Sometimes some of his patients go home, they just suffer with eye drops. So that's kind of a driving force for this study, actually. Yeah, it's a few years ago. Then when we got this and tried to optimize the formulation, because this is the very first study we published. But right now, our goal is just generate a new polymer, can give us a good drug loading, very high drug loading, which means you can minimum the use of polymers. The raw materials, you don't want to inject too much in the conjunctival tissue. But you can give you a very long, not very long, 1 month release of the drug. That's perfectly match the clinical application, requirements. So this is the goal. Yeah. Thank you so much. Yeah.
Thank you.
Yeah.
Thank you.
Thanks.
Okay, so we do have the break for lunch right now, and we'll reconvene at 1:40. So in an hour.